For presenting the telehealth information. We found it incredibly helpful when we used it in our group. Sorry to join the meeting late. Welcome, everybody. I'm going to let Matt get started because I don't want to waste time.
Okay, well, fair enough. Well, thank you so much for having me. I realize, too, this is really somewhat of a broad kind of topic because telehealth has kind of become a part of our practices very quickly. I think for a lot of us that weren't using it before. And so certainly I'm happy to share a little bit of some of the experiences that we've been able to have on the inpatient side at Vanderbilt, knowing that some of our partners certainly use this as part of their outpatient work as well. And so certainly, realizing that everyone, I think, is still catching their breath a little bit when it comes to all of this, I'm very happy to kind of share that kind of the information that's out there, some of our experiences, and then certainly to add, and let's see if other folks have other tips or information or other things that they really want to add as we get to the end of everything. So really from the source themselves, so from CMS, all of this has really started since March. I think as all of us have been kind of adapting, we realize that under this 1135 waiver, the Centers for Medicaid and Medicare Services have really allowed us to try to expand this in the midst of the pandemic. And it'll be fascinating to kind of hear by the end if other folks have been using this as part of their regular practice previously. I'd love to know kind of how people have adapted in their own practices. But this is kind of the rule that has let us kind of flourish in this area over the past several months. And I think a lot of us are finally starting to get our feel for things, just as we kind of see how the practice will kind of maintain over time. Of course, the biggest part of all of this is that for true telehealth or for true telemedicine, which really kind of get used interchangeably, it's the use of interactive audio and video systems that allow such communication. And really what CMS has identified is that, with some adaptation, obviously, being able to do what exam components we can over video, kind of hearing and using on-site help as much as possible to be able to get those elements that we used to do in person so much, that really a really wide range of practitioners can use this to help supplement their practice. And in the midst of everything with the pandemic and the attempt of trying to stop the spread of COVID, the rules have really been loosened very quickly to let this really supplant that in-person visit until things calm down again. So for all practical purposes, a lot of these rules and changes are intended to help telemedicine really replace the in-person visits that we're all used to. One of the exceptions that has come along with all of this, previously telehealth was expected for only those patients that you've had a previous relationship with. So, ideally, you've met this patient in person before being able to kind of rely on just the electronic measures to evaluate and continue conversations. But during this time period, HHS is not going to conduct audits to make sure that such a prior relationship has existed. Now, in the language of practicality, that means that we can use these methods for people that we haven't met before. It's not the most reassuring of language, but I am assured by others that this actually does meet the standard that we are allowed to do this. I know it's always a big difference between you are allowed to do something and we're not going to pay attention to whether you're doing something, are probably two different standards, but for all practical purposes, it seems that everyone is in safe waters by trying to use this even with new patients as we go through. And so really to cut to the chase, what I wanted to do is kind of talk about the different levels that have come out of all of this, everywhere from true telehealth that I think a lot of folks have really adapted to, all the way to different variations that may be helpful in other circumstances, even as we move forward with everything. So as we talked about a little bit earlier, the idea of true telehealth is using a combined audio and video system. For documentation purposes, you document as you normally would for any other encounter, documenting the elements of the exam that you can through that video interaction. The modifier that you use to indicate that it is a telehealth is the 95 modifier, added on to what your other CPT codes would be. Now, one of the things that certainly impacts the palliative care aspect of all of this is that we can use telehealth in various ways for advanced care planning discussions. So the same codes that are billed for advanced care planning, the 99497 and 8, can still be used with telehealth through an audio and video system. That is also one of the few exceptions to encounters where the patient does not have to be on that interaction. And whether this is through telehealth or even by phone, you can have these interactions with the surrogate if they're going to be the ones making decisions and actually making kind of future care planning decisions for the patient in question. For every other activity, though, the patient has to be included. And so I think that makes a lot of intuitive sense. But remarkably, telehealth has been expanded to include a huge and vast array of visits, all the way to ED visits, nursing home visits for initial and discharge, even critical care visits in some situations can be done through telehealth. Now, one of the things that came up very quickly, and I'm sure that this will be kind of one of those questions of what people's experience have varied based on your institution and your location, is what are we allowed to use for these telehealth platforms? We can speak to our experience at Vanderbilt that we initially used Zoom at the very beginning and then started to use a platform through our electronic medical record. From CMS's standpoint, yet again, the most reassuring language is that essentially Health and Human Services is waiving the HIPAA enforcement penalties for providers that are trying to use other services that in essence should be secured but are a little harder to actually guarantee. So very common apps like FaceTime, Skype, other things that you may be familiar with. And really what HHS has said is because of the urgency and because of the circumstances that we're in, if you can use this with apps that people already have, that they're not going to start looking at HIPAA compliance for these particular platforms, realizing the unusual situations that we're in. There's no word that I've been able to find on how long that will be the case. I think we are still kind of in the catch-up mode, it feels, in a lot of regards. But at least for right now, CMS has kind of given us the green light to be able to use those platforms and those services that our patients are comfortable with. Now, of course, the CMS also realizes that not everybody has access to audio and video, even though the smartphone seems ubiquitous nowadays. There are certainly folks, and let's be honest, there are certainly folks of certain generations that are just not comfortable using technology. And so telephone encounters are still a feasible way, especially when we talk about advanced care planning. So there again, in the palliative care realm of things, those advanced care planning codes, the 994, 97, and 8, can actually be conducted through an audio-only encounter. A lot of the counseling codes that we use, so things like for tobacco cessation or alcohol intervention, there are a lot of behavioral health, nutrition and obesity counseling. There are actually quite a few different things that are billed really the same if you do a telephone encounter only. Realizing that most of our other E&M codes, most of our other encounter codes are not going to carry the same weight if you don't have that video evaluation, if you don't have some level of being able to see and evaluate the patient. You can still have some level of billing that may be able to come from the time that you've spent, but that coding is going to come at a much lower billing level than what you would normally expect. One of the things that we'll talk about towards the end is really when we talk about advanced care planning, kind of what's covered there, how we document it, and the reimbursement for that. This can actually be a very big difference maker in how we do our palliative care in really any setting, whether it's inpatient or the outpatient. I did want to make just kind of one quick mention. I think this is something that I've heard people kind of talk about, certainly more appropriate for those folks in our outpatient setting. But one of the things that has been around for quite some time that is a little bit more front and center as we talk about all of this is the idea of an e-visit. Of course, I think a lot of times, as those of us who have started to use online portals through our electronic medical records, we're no stranger to the idea that there are some patients who will really seek out quite a bit of effort in trying to engage things just through common questions and interactions through the portal, not by phone, not by video, just messages back and forth over some period of time. And so just a quick mention that effort as well, if you are actually using a relatively small portion is all that's required of time. If you're using that time over the span of up to 7 days to actually make determinations in the evaluation of your patients, that effort actually can be billed as well. They're not going to bill a whole lot. And I've heard some people question, is it worth the time it takes to put in a code to actually do all this? But there are at least ways, if you have those really complex situations, certainly as you're getting into I'm spending 20 minutes or more over the course of a few days trying to address issues that are going on with my patient, there are ways at least to try to recoup some of that time. The American Academy of Family Physicians has put out this actually really nice algorithm. And Anna Lee will have a copy of all of these slides, so anybody that's interested can get these directly. They're very easily findable on the internet as well. But the AAFP put out a really nice algorithm of how do I figure out what general area I'm going to start billing if I'm starting to use telehealth for my patients. Kind of seeing if there's video and it's real time, that this is where we are, that this is telehealth, and very likely this will be one of those new way of things, a change that will probably last with us in some capacity from here forward. If it's not real time, if there's kind of audio and video, but it's something that the patients have sent you a message, some way that you can kind of see and evaluate, but it's not a true interaction, there are actually codes for that as well in what are called virtual check-ins. Even if you're just using telemedicine in some capacity to determine, does this patient need to be seen in my office or not? You can actually do special coding for that. If the patient is just on the phone, again, in general, you're going to think about lower billing levels, but there are ways to make sure that that time is still valuable. One word that I will put in as well, one of the experiences that we've had, and certainly if anyone else has had these, would love to hear about this kind of as we share as a group. We as a group, kind of in the initial stages of the pandemic, tried to figure out ways of trying to provide good palliative care while protecting our team, realizing that if we get exposed, if we get sick, we could really leave our institutions without, as it sounds a little cocky to say, but we'd like to think we're a valuable resource and probably worthwhile trying to be cautious about all of this. As we've learned, we've kind of gotten back into more routines with our protective equipment, but in the early days, worrying about exposures and things, there are actually a few different variations of this that you can use. So for those of you who do inpatient consults, there are actually electronic consultations that you can use without even seeing the patient. And you can, and there's a lot of variability. The reason I didn't go into this kind of in detail in slides here, there's a lot of variability of this based on region and probably based on what your institution has familiarity with. But there are ways of doing teleconferencing with other teams so that those curbsides of, hey, can you help me work through an opioid issue? Hey, can you help me kind of think through this patient situation? If you're not necessarily seeing the patient, but providing some level of service, there are actually ways of doing that as well. And so I would encourage, if that's something that you do on a regular basis, certainly talk with the coding and billing experts at your institution. It's not something that gets done very often, which is probably why a little bit of specialist help in your particular situation is highly advisable. But there are ways of making sure that that time is valuable to you as well. Just a quick mention, of course, all of these rules are really kind of coming down from CMS, and we know that at least through October 23rd, they have said that they will continue this type of coverage for telehealth. A lot of other private insurers, of course, are going to follow suit. There's always a little bit of variability in this, and so it's something that everyone is actively watching. But as of right now, these are kind of the most recent updated numbers that we've heard for other providers continuing to make these coverages as well. I did want to spend a little bit of time, without taking too much of the day for everyone, talking about the idea of how we really bill advanced care planning as well. I know this is something that for us can seem so old hat a lot of times, but really is something that there's a special niche carved out for how we bill this when we're talking with our patients. I think so many times we can really start to fall into it. It's just a natural conversation for all of us to have, but it is something that is actually billable separately, realizing the importance of all this. What has to be mentioned is that from CMS, and I'm sure all of you probably remember the debates around how do you pay for advanced care planning and the politics that got involved as all of this came as part of the Patient Protection Act and everything else. It's complicated, but basically what came out of this is it has to be voluntary. It's not something that you can force advanced care planning onto your patients, not that any of us ever would, but knowing that that's a concern of lawmakers in various quarters, it is something that the patient or the surrogate has to say, is that something that they want to do. And so really this has been defined as as a service, either with the patient or surrogate, to discuss advance directives with the goal of those issues that can be documented in some form or fashion, and helping people to record those wishes, really focused on what they want their medical treatment in the future to be if they lack capacity at a future time. And this is where things can get a little bit blurry as well. I know we in our office talk about oftentimes what's the difference between spending time talking about someone's goals of care versus their advanced care planning. And really that emphasis is on, in the future, what would you want your wishes to be? If we're talking about a complex situation right now, that's not really what this is intended to cover. What's important to realize too, it is not required that documentation is completed. These issues are certainly things that would be covered under advanced care planning documents, living wills, the Tennessee Advance Directive, post forms, but including issues just as simple as surrogacy or code status. The completion of these things is not required. It's the time spent in pursuing these overall goals. That's the actual minimum requirement. These can be added to a routine E&M visit and can be done in any location. There is no location restrictions. So this can be done in the outpatient, inpatient, or nursing home setting. There are a couple of caveats that you have to be aware of. They cannot be billed the same day as any critical care services. So for those of us on inpatient services, talking to our ICU folks, if our ICU providers have provided critical care that day, these will not be billed. It should also be noted, and this is one of the issues that you'll have to talk about with your patients, part of that voluntary nature of all of this as well, is that these codes are billed separately. And so your patients very likely will face a separate copay if you bill these codes. In the midst of a 14-day hospitalization, that may not be very noticeable or may not be overly meaningful to a lot of patients. But if this is an extra charge that your patient gets 2 bills for their single visit in your office, that is something that a lot of folks take notice of. I know that our partners who have worked in our outpatient clinic are very strategic about how they try to bill these codes, even though they do advanced care planning on a regular basis and have the ability to bill on a regular basis. They have gotten pushback from their patients of why they have to pay a separate copay just to have these conversations. There are issues with this, again, at a much higher level than any one physician or one group can address. These are CMS level determinations, but it is something to be aware of so that you avoid, if you're going to bill these, it can really behoove you to have a conversation with your patients about why it's important to talk about this and that there may be an extra copay that they face in doing so. One of the ways that this really starts to play out, again, a lot of these conversations can really be lengthy and involved and may involve kind of a comparison of what a prolonged visit might look like. And so really for comparison, just to give you an idea of how this can be beneficial on the physician side of things, you can kind of see very quickly if you're getting into these, and again, we face this, I think, probably more often on the inpatient side of things, although certainly it's not unheard of in the outpatient side to have a lengthy time spent with patients every now and then. You can kind of see that the amount of RVU, the amount of effort that's generated based on just spending that amount of time versus doing so specifically for advanced care planning, advanced care planning does bill at a higher rate. And so it can actually make a significant difference for those of us who are doing this on a regular basis. Important to talk about what the requirements of this are. I will say that the guidelines vary fairly drastically. One of the great sources that you can find a lot of information about this on is from the Center to Advance Palliative Care, CAPC. They actually have a lot of recommendations from their providers in the New York area where they work on specifically talking about the time in the room, the time out of the room. They are very detailed in their documentation. I will say, talking to our billers and coders at Vanderbilt, they have been not nearly as stringent and said that, from the indications that they've gotten from our local coverage provider, that level of documentation is not necessary. Here's what everyone does agree on. Anything that you're going to document as part of this discussion, of course, review what you've discussed. Kind of having an idea whether or not anyone has completed documentation or this has been formalized, making, kind of providing that more so than saying I had this conversation. Of course, it just makes good sense to make sure to know that we're kind of talking about what we've talked about. The time spent on these discussions, the closer to the minute, the better. These advanced care planning RVUs are based on chunks of 30-minute time blocks. So the language that CMS uses is, of those 30 minutes, if you've spent a majority of that block, so really 16 minutes, that's where you can start to bill an extra level up for the advanced care planning that you do. So if I go back for just a moment, you'll see why these odd numbers of less than 15 minutes is not anything. 15 minutes is the minimum, really 16. So if you spent the majority of your first block, that counts as one block. If you spent the remainder of that, if you spend the remainder of that plus the next portion, that another 15 minutes of the next block, that's where up to you get that 16th minute, that's where you start to build that next RVU. So it's really in these kind of block and a half sections if you're going to spend lengthy amounts of time with your patients. As far as documentation, of course, any decisions that they make, please document it, and any documents that they complete. That also, the completion of those documents counts towards this time. One of the things that also feels a little bit uncertain, but is covered under CMS guidelines, if there's an amount of time, and you kind of wonder, like, how would we spend over an hour talking about some of these things? You know, if there is education that's necessary to be provided to allow that patient or surrogate to have these conversations, that can be included in all of this. So if there's a prognostic awareness issue, or if there's a coming to terms issue, dealing with that can be included if the goal of that is to talk about what those future wishes are. This is the documentation that we use at Vanderbilt. This has been approved by our billers and coders, and it should be said, in regards to any of these issues, I kind of use the fact that no one has yelled at me yet, means that I'm hopefully doing something okay. But this is the actual language that we use in our electronic medical record, indicating the number of minutes spent and whether or not the patient has or has not completed the documentation. In addition to this, we will also include what have we talked about, the nature of that conversation. Again, this by itself is technically sufficient, but also likely suspicious. So any indications of what the issues were that were talked about or education that was provided will go a long way to making sure that documentation is where it should be. As I mentioned, some people like to be very particular. Some areas have higher requirements that's very locally dependent. And so if you hear differences in that, from what we've heard, that can be an issue as well. It should be said, I am a novice at this, let's be honest. I've taken an interest to make sure and try to help with our group understanding and doing this in a better way, and which is why I'm happy to come and talk about our experiences. Let's be honest, there are people who are much better at this than I am. And so again, one of those fantastic resources I can't encourage you to visit to talk about enough is the CAPCI website. They have a fantastic section on how do we deal with COVID-19, how is telehealth affecting what we do as palliative care practitioners. There's a lot of really great information there, and I'd highly encourage you if you still have questions after all of this. But with that said, happy to talk about anything that we can right now, questions that you all may have, or conversation is where it may go.
Can you see the questions?
Let's see. Let me back out. I'm getting used to WebEx. This is, well, I can't pull up my, see, you jinxed me, Mahana. You talked about I'm a guru, and now I can't pull up my chat function.
I've got one question in the chat box, and I can ask that while you look for it.
Please do.
This is from, and I'm very sorry, I didn't introduce Jessie Turley to begin with. Council member, she is the representative from Alive Hospice that has joined the council. I'll send out a bunch of information about her later. But the question is, it says, great info. Can social work bill ACP in their inpatient setting independently?
That's a great question. And I tried to look this up, and this is where I want to be very clear on what I know and what the language actually says. So what the CMS guidelines state is that non-physician practitioners are able to bill these if they are already able to bill independently. What seems that is clearly covered under that are nurse practitioners and physician assistants. I tried to find at what level because I know in a lot of of places, social workers will actually do the advanced care planning with folks. I cannot find specific language that says whether social work specifically is able to do so or not. And so really that may be a great question for the kind of the local coverage companies. And your billers and coders. I was trying to see kind of, because realizing that we have both social workers, case managers, other folks that are involved in all of this, the language from CMS is a little bit murky. So I want to be very cautious in giving you an answer there. Really what the language specifically says is if any particular clinician level allows them to bill independently for a service, they can still do that. One, I know through telemedicine. I could not find specific information on whether social workers can bill independently for ACPs, but other folks may know and be able to provide. As I say, I see it. There's a thought that LCSWs can bill, but MSWs may not be able to.
Yeah, that was from Dr. Phelps. And Jesse, I'll make a note of this, and we can do a little bit more digging and get some more answers for that as well. Other questions for Dr. Peachy? I've been putting in the chat box. Feel free to put your question in there, and I'll relay it, or unmute your phone and ask away. Oh, there's one question from Jill. Greg, has your program had success in getting reimbursed for LCSW ACP work? Dr. Phelps, I'm not sure if you want to answer that, or we can get more information about that later too.
I've been trying to find out whether we're getting paid for our LCSWs. I know previously we had not been. We took a beating on our last LCSW, so we're trying to figure out what we're doing that's not getting us billed.
That's good information. Other questions or comments for Dr. Peachy?
I just wanted to make a comment, a question. The revenue that people can bring in for advanced care planning, this is more just an FYI, can be actually pretty sizable. I met with our division chief, I think a couple of months ago, and he was telling me that one of the primary care physicians will bill maybe like a third to a quarter of his salary in advanced care planning, because he is so heavy in terms of making sure he gets all that documented. So the revenue that you can bring in is actually not trivial. The other thing that our group, institutional leadership, was looking at is kind of what counts as advanced care planning, and Matt had talked about that in detail. But from our leadership's communication with CMS and review of what they have, every institution is able to define what they constitute for advanced care planning, as long as you have that systemized somewhere in your policies or procedures. So in our institution, we have pulled in goals of care, advanced care planning, identification of surrogates, filling out documents, all of that. So to get to that number and those buckets of time that Matt was talking about, you can actually do that pretty reliably and compensated in a way that makes sense, where it's worth your time.
One other thing, can somebody say they can hear me or not?
Mm-hmm. We can.
Okay. One other thing, or two thoughts. One is I have a horrible time getting my nurse practitioners to actually document and bill for doing advanced care planning. It's kind of a sore point on our monthly call-ins. I will actually call out the people who've not, they've seen 20 or 50 patients and they haven't done one advanced care plan. And I'm like, guys, this is a crucial part of what we do. The other is we always include in the advanced care planning language whether we thought the patient had capacity, and if not, who was doing it, because we've had families come back and go, oh, well, they had dementia also. You can't go by what they said. So we always try to be upfront and say, whether we thought the patient had capacity at the outset.
Absolutely, and I think I didn't include that as part of kind of one of those essentials, but certainly it is who you're talking with. Certainly we will be very, very thorough about, was this with the patient? Was this with the surrogate? Ideally, both in some capacity. But realizing that those mentions can be extremely helpful, not only to the thoroughness of the billing, but in those situations where we may be handing off care to other people, or as I kind of tell our learners, leaving the trail of breadcrumbs for those folks that we're going to be taking care of for prolonged periods of time can be a fantastic way of making sure that we know what we've talked about before, and how to make sure that communication flows through.